Good morning. Okay, good. Now you all can hear me. So, for all of those who could not hear me, I was saying welcome and good morning while people were logging on. And up on the broadcast, we have a few announcements about events this coming Friday. So, on Friday is the long-awaited Kumba dance team performance at 1 o'clock on the Dean's Lawn. If you all recall, this was going to be in February, but if you recall, there's a lot of rain in February. So now it's in June, around Juneteenth. So please come out for that event. It will be fabulous. And next slide, right before then, you can meet Dr. Cornell West, who I met 20 years ago and is phenomenal. And that's from 11 to 1. And then at 1, you can go over to the Kumba dance team. And next week's grand rounds is the great Dr. Dean Winslow. He always talks about how we need more heroes in medicine. He is one of those heroes, and he will be presenting about this topic of COVID-19 testing in refugees and unaccompanied children at the border. So without further ado, I'm going to introduce you all to our speaker today. So I have the honor of introducing my friend and dear colleague, Dr. Benji Laniakea. They graduated from the University of Buffalo School of Medicine and Biomedical Sciences, and subsequently completed the UCSF Family Medicine residency program, after which they joined our faculty. They are a beloved educator and have served as theme lead for the sex, gender, and sexual function curriculum here at the med school since 2018. They were recognized with the Arthur L. Bloomfield Award in recognition of excellence in the teaching of clinical medicine. Recently, they have also been appointed, after a national search, as clinical chief of the adult LGBTQ+ program here at Stanford Healthcare. And today we'll talk about their vision of comprehensive, full spectrum care for our LGBTQ+ community. Dr. Laniakea, take it away.
Thank you so much, Wendy. Oh, can you hear me on this? Great. So sometimes, again, I'm Benji Laniakea. I use they, them pronouns. Sometimes I get asked why, I got into LGBTQ health. And frankly, it's because I grew up with a lot of LGBTQ folks. I grew up in LGBTQ youth groups. And when I was there was just a general consensus that the doctor wasn't necessarily where you went to for good healthcare. You got advice from your community members. You went with very specific symptoms or described very specific things to your doctor so you could get the care that you needed, right? My friends who became HIV positive were terrified that they would go in, and when they did go, they were shamed and blamed for their own diagnosis, and they had to deal with that in order to receive their care. In medical school, our LGBTQ curriculum consisted of a single question on a single exam, which was, this man is flying around having sex with lots of men in lots of cities and doing various drugs. And the answer, of course, was that he had HIV. And I'm here to tell you that there's so much more in LGBTQ health and so much more we can do to make the members of our community feel welcome and not just tolerated, but celebrated in our community. So happy Pride, everyone. I have no financial disclosures. If anyone has any idea how to become very rich by becoming very gay, please let me know. The hormone therapies that we may describe and talk about are not FDA approved. These are for gender-affirming hormone therapy for gender-affirming care, but they're considered standard of care by Endocrine Society, WPATH, the World Professional Association for Transgender Health, the American Academy of Family Practice, American Academy of Pediatrics, etc. So why do we want to talk about this? Well, if you take a look at this graph here, right? This is a Gallup poll study, survey, which just shows what is the preponderance of LGBTQ plus individuals, and over here we see it's very confusing. For whatever reason, baby boomers and Gen Z are the same color, but this line up here at the top, they're going from 10.5 to 20.8%. That's Gen Z, right? And so, as of 2021, 20.8% of Gen Z identifies as somewhere in the LGBTQ spectrum, right? Now, sometimes people say, "Oh, this is just this is Everyone's becoming gay. Everybody's going to be gay. And so to this point, I like to point out this. This is a graph of left-handedness from 1900 to 1976. And you'll see it started at only 3% roughly. And now, it's cresting 12% at 1950. This is a crazy fad. Everyone's going to be left-handed. Well, of course, we all know that didn't happen. And what ended up happening, it was just kind of peaked at about 12%. Turns out once we stopped telling people that they were demonic and that there was something terrible about being left-handed and that they should try harder to be right-handed, well, I guess attitudes changed. And we kind of just allowed the people to come to the natural population percentage. Now, I can't tell you exactly what that percentage would be. I don't have that crystal ball with me yet, but I imagine it will very quickly plateau to whatever the percentage is. Needless to say, though, it's higher than previous demographic surveys may have indicated, because people are now feeling more comfortable and more safe coming out. Now, even with people feeling comfortable and safe, we still have a lot of roads to go. We've got a long, long way to go. We have, in this survey from 2021, the Kaiser Family Foundation found that our patients who are LGBTQ, they get these negative experiences that are not reflected by their non-LGBTQ counterparts, right? Healthcare is not believing they're telling the truth. Healthcare providers assuming something about them that wasn't necessarily true without them asking. And being overall dismissive of the concerns of the LGBTQ population. When monkeypox started up last year, I had several friends who went to their provider and said, I think that something is wrong. And they were told, no, it's nothing. Or, oh, this is just a normal rash, or and it said, no, it's much more painful than anything I've experienced before. Please, can I be tested? Please, some of them even went in and said, can I be tested for monkeypox? And they were dismissed. And then, of course, we all know what happened afterwards. When we compare even out, and this navy color is our gender nonconforming, or rather gender expansive and gender diverse individuals, including non-binary and transgender individuals. And this kind of ugly pea green color, that's our lesbian, gay, and bisexual individuals, right? So when we separate out our gender diverse patients from our sexual diverse patients, we see even worse outcomes, right? 65.2% of, and this graph is a little dated, I will say. This is from 2011, so I don't want us to maybe, it's probably a little bit better, but I think it still holds fairly true. 65.2% of providers were unaware of the health needs of our gender diverse community. Not just, this isn't my specialty, but let me connect you, but rather didn't know what at all would help these patients, right? And these outcomes don't just start with poor medical practice. They get to physical abuse, physically rough over here, 7.8%. That is not a small percent of people to have experienced physical roughness in a medical office. And furthermore, it's not, again, this 2011, even though I said that's a long time ago, it's not like these attitudes are changing quickly enough, right? Over the last quarter, a record number of anti-LGBTQ plus legislation, especially focused on anti-transgender laws, have been submitted to state legislatures. And this number is actually 155, and there's, I think, over 400 in the first quarter of 2023. So if we look over here, yep. So now, granted, less than 10% of those do get enacted. So, I don't want to say like over 400 new anti-LGBTQ laws. I don't want to blow it out of proportion, but certainly, like, there's strong effort from more conservative portions of the state legislatures, trying to make being trans, make being LGBTQ plus illegal, right? And having and this sentiment is causing huge ripples through the LGBTQ plus community. Our patients are reporting massive depression just by reading the news. They feel like their right to just simply exist is being challenged. Here is just kind of a map showing where our anti-LGBTQ laws are most concentrated. You'll see that, of course, California here, where we are, is a state with the most protections. So for those of you who are saying, like, I don't see that, I don't think that's, well, that's because you're in a very safe space, right? But even with this, we know that in Glendale yesterday, in the last 24 hours, there was actually an anti-LGBTQ plus protest where the anti-LGBTQ protesters assaulted the pro-LGBTQ parents of students at Glendale trying to advocate for a recognized Pride Month. And moreover, even more concerningly, while efforts up to this point have been mostly steeped in rhetoric about protecting children and how children can't make, irreversible decisions for themselves. I mean, and I'll let you know that natal puberty is also irreversible, but that's a whole rabbit hole we'll get into at another point, right? In Florida, recently passed an effective medical ban. I say this, and then people are going to say, well, hold on, it's not an effective medical ban. All they have to do is get, in order to continue gender-affirming hormone therapy, adults, 100,000 adults in Florida must have an MD sign off and sign in informed consent medical forms. And you might say, well, okay, that's not so bad. Even those who are previously seeing a nurse practitioners or physician's assistants, maybe hadn't had a one-to-one face-to-face appointment with the MD. All they have to do is get that appointment with the MD and sign those papers. Well, the papers don't exist, right? The medical forms have not been approved by the governing body in Florida. So the forms cannot be signed, so hormone therapy cannot continue. Of course, there's appeals going to the courts, but you can see why folks are calling it an effective ban. So we're going to do a quick game. I promised I'd make it a little interactive, right? So gender-affirming surgery, what do we think? And you don't have to answer out loud. If I'm waiting for an answer, it's very awkward. So I'm not going to ask you to answer. But what do you think the rate of regret? People are saying, what if they regret it? What if there is a mistake? What is the rate of regret for gender-affirming surgery? Well, it's less than 1%, right? Less than 1%. And out of these 1%, well, I'll expand on that in a second. Let me go to our next slide. What is the rate of regret for total knee arthroplasty? Does anyone have just thinking about? 11.6%. It's over 10 times the rate of regret for gender-affirming surgery. What about spinal surgery? I think everyone knows this one, but yeah, 20%. It's 21%, right? And not only is it 21% bad outcomes. That's not what we're measuring. Of the patients who were asked, 21% that they regretted the choice they made in spinal surgery. Not that there was complications, so it was bad, and 21%, but 21% said surgery caused them harm, right? As opposed to less than 1%. Moreover, when asked, though that 1% of transgender individuals who regret surgery are often regretting it because complications. This is a new surgery because of the attitudes of medicine to this point. In doing these surgery, the surgeries have not advanced to the point where complications are low, right? Phalloplasty up until the last 10 years had a nearly 100% complication, but patients still were willing to take that risk, even when informed that there was a nearly 100% complication rate, right? And in people regretting it, often they're very, very rarely regretting it because they say, this was not the right choice for me, but rather they're regretting it because the technology was not advanced enough. Or rather, I did this and my parents didn't approve, they kicked me out of the family. I did this and my job fired me, right? These are the reasons we're regretting it. I don't think it's quite synonymous with the rates of regret for spinal surgery. So we believe, we have here, and I want to take a second to kind of advertise for myself and for my program. Again, Wendy mentioned that I am honored to be the clinical chief for the adult LGBTQ plus program here at Stanford. So for those of you who didn't know we had an LGBTQ plus program, we have an LGBTQ plus program, and we're awesome, actually. Compared to other LGBTQ sites across the country, we're actually incredibly robust, and we provide not only full spectrum LGBTQ plus care, so that means everything from taking care of primary care, endocrinology, dermatology, psychiatry, OB-GYN and reproductive health, family building, surgery, including ENT and vaginoplasty, gender-affirming surgeries, right? And growing, we also have social work on board now. We have physiotherapy on board. We have quite a few. Quite a few specialties that have all decided that they really want to be a part of this program and provide, again, robust, full spectrum, longitudinal care. Right, our youngest patients are in pediatrics. Some of them are just kind of exploring who they are, and they want a safe space to be able to do that. It's not like we're providing hormones for prepubescent children. That's not what we're doing. We're not doing surgery and hormones in prepubescent children, but in order to have them have a space which is comfortable to be themselves and to experience who they are, right? And we have patients who are just starting transition in their 70s, right? And this is something that they've been hiding their whole life because they didn't feel safe, they didn't feel comfortable. They felt that they had a duty or obligation that they needed to commit to their families, and they wanted to wait until they really had completed those, so they could really feel like they're starting their own life. And we want our program to be 4 things. First thing, a patient-centered medical home. Our clinic is based right now in Los Altos, where we share space with the wonderful Los Altos Stanford Primary Care program. It's fantastic. It is a spot where our patients have said they feel safe, comfortable. One of our patients said it's the space she feels most comfortable in the entire Bay Area, which is some glowing praise for us. And not to toot our own horn, but again, we spend a lot of time making sure that this is somewhere where patients feel respected, feel safe. Every time there's even a single patient complaint, we sit down, we have a gemba, we evaluate everything about what we're doing in order to see if we can make this space better, safer, and more robust for our patients, right? So it is a single spot that patients can get most of their medical care, including primary care. We also want to be a referral service for our colleagues who say, hey, I want to be, I'm still want to be primary care. The patient loves working with me. I love working with them. We're not here to steal your patients. That's not why we're here. And if you're a specialist working with a patient and say, oh my gosh, this patient could benefit from LGBTQ specialized care, including screening or gender affirming care or perhaps sexual health, great, that's what we're here for. We take referrals. We would love to see them. We're also here to be a consult service for our colleagues. Some of you may say, well, I don't know a lot about how gender-affirming hormone therapy works. Maybe I remember from endocrinology in medical school, but how it's exactly applied in our transgender patients, for instance, I'm not really sure the dosing or what other monitoring. I would love to know more. We'd love to talk to you. We'd love to come either give a presentation, kind of like I am right now, or perhaps we can even give a one-on-one consultation. You can reach us. You can reach us through Epic, or you can send us emails. We would love to talk to you to make sure you have the ability to take care of our patients just as much as you want to take care of them. And we want to be a site for pedagogy. We want to make sure that our students are learning. And right now, our students are literally fighting each other in order to get into our clinic, in order to spend time face-to-face with our patients. This is one of the highest reviewed sites for clinical care for our students. It is a place where our students feel like they always report that they're getting great face-to-face education that they can't get anywhere else. And it is just such a unique opportunity. We want to make sure our students, all of them, even the ones who don't rotate with us, get to graduate with the ability to have the compassion and competency to take care of our patients wherever they end up in life. So I'm going to take some time now to just kind of review some of the things that we're able to offer at our LGBTQ+ program. And if you have any questions, we will save some time at the end to answer them. But starting off, so we do, of course, provide gender-affirming care in our program. This is something that I kind of spend a lot of time specializing in. It's in the community. This is what I'm known for, especially. Of course, we do gender-affirming hormone therapy with testosterone and estradiol. We also do sometimes hormone therapy for our non-binary patients, which may include both or neither of these things. We have now the surgeons who can do breast augmentation, vaginoplasty, and or orchiectomy. We're still working on getting phalloplasty here at Stanford. We have laser hair removal through our wonderful dermatology program. We have gender affirming vocal pitch surgery at ENT. We have gender affirming chest reconstruction through plastics, and we have hysterectomy and salpingo oophorectomy through OB-GYN. As far as sexual health goes, we provide comprehensive sexual health services, including STI screening and PrEP or PEP, right? Sometimes folks may say, hey, we ordered gonorrhea and chlamydia, we ordered, the HIV testing, that's a wrap, but we have to sometimes think about how the patients are engaging in intimacy and sexual practices, and there may be a screening beyond that, including sometimes screening for HPV, depending on again, the intimacy practice of the patients, right? We want to do contraception with patients of all body types, right? Sometimes we have to think a little bit more creatively about how we're doing contraception and the risks and benefits. Sometimes for our cis female population, for instance, Paragard is often frowned upon because it may worsen menses, and for a lot of patients, that's not a desirable effect. However, in our transmasculine individuals, having increased menses while having no menses because we're blocking menses with testosterone means that we've actually negated that. And for folks who don't want any female hormone, even though we all probably don't think of progestins as feminizing, this is a way that we can allow our patients to avoid the dysphoria of having what would be considered female hormones and still get the contraception they need and for longer, right? Because since Paragard lasts longer than hormonal-based contraception. We also want to make sure we have sexual health counseling that's appropriate to forms of sexual intimacy. We have a lot of patients that come in and say, I want to discuss my anal health. I've been often told that this is something that doctors don't want to discuss or maybe don't have discussion. But for our MSM, that is our men who have sex with men, that's gay and bisexual men primarily, but it's also more expansive than that, right? In this patient population, often the anus can be thought of as a sexual organ, right? And we have to think about how can we best provide healthcare coverage and screening for patients who are engaging in rectal intercourse. When we talk about family planning, typically speaking, outside of the LGBTQ program, we're talking about contraception or perhaps about pregnancy management, right? In the LGBTQ plus community especially, we are often talking about family building, right? And at the reproductive endocrinology, we now have Brent Mansour, who's doing some phenomenal work with family building for our LGBTQ plus families, talking about how do we do fertility preservation for our patients who may be undergoing gender-affirming hormone therapy, since gender-affirming hormone therapy may cause cessation of natal gonads, right? May cause atrophy of testes or of ovaries, right? So how do we make sure that if the patient wishes to have fertility, wishes to have a family, that we preserve those options for the future? Right? We want to make sure that our patients who don't necessarily have two gametes that will create a pregnancy without intervention, how do we make sure that they have all the options available for themselves so that they can have a family? Just a lot of our LGBT patients have given up on families because they've just assumed that there's never going to be a place that there's going to feel safe, comfortable, and with expertise to help them out. But we are quickly turning that on its head, and we have a lot of patients who are lined up to work with Dr. Mansour in building their own families. We, of course, partner with the Positive Care Clinic to offer primary care for patients undergoing management of HIV. And we're also working with our communities to, as soon as we heard about MPOX and we started working with them, we started figuring out ways that Stanford could really work with community to distribute the vaccine and curb the rate of infection. And I don't want to say that Stanford was the only gear in the machine here. Of course, the counties were working with us. The CDC was working with us. We were making sure that we had all of these resources available to provide for our community, but we certainly galvanized and mobilized faster than a lot of organizations. And again, not only because of Stanford, but we saw rates of MPOX reduced dramatically in the community once after the epidemic started last summer. Cancer screening is also a little bit different in our LGBTQ plus patients, right? Especially for our gender affirming patients. the organs that are present have to be screened for cancer, right? Our current electronic medical system says women at this age get screened for breast cancer. Women, men at this age, you should consider doing, prostate cancer screening, right? Let's think about, rather than saying men or women, right? Or rather these, this broad demographic, base it on organs, right? Let's talk about how we can screen anyone with a cervix for cervical cancer. Let's think about how our patients, whether or not they're going to develop their breast tissue during adolescence, or perhaps when they're 50 and starting hormone therapy for the first time, how do we screen for breast cancer appropriately and make sure that we're following guidelines such that their risk is minimized? And how do we develop data and push research such that this is something that is going to be not just not just for our patient population, but generalized for people who maybe perhaps see patients in this demographic less frequently than we do, right? We're currently, of course, working with the We Ask Because We Care team and trying to figure out how do we make sure our electronic medical system also flags these patients in a way that is consistent with evidence-based guidelines rather than just their legal sex or sex assigned at birth. Mental health is one of the most important services that we can offer our LGBTQ plus patients. It is the #1 cause of morbidity and mortality amongst our LGBTQ plus patients. And we are integrating behavioral health into our LGBTQ plus clinic. We're partnering with the Thrive Clinic, and we're partnering with PCPH in order to bring mental health services to our patients who need them most. In order to, when we know that when we provide excellent medical care to our LGBTQ plus patients, especially our gender diverse patients, and we do that as early as possible, we know that their rates of mental health complications go closer to baseline when they receive the gender affirming care they need and the mental health services they need. And we want to be able to make sure that Stanford as an organization is advocating for the LGBTQ plus community. We have such a powerful voice, and we can say things backed by science. We can say things backed by the expert consensus of some of the most prominent physicians in the world. When our communities are facing such strong opposition, as we mentioned earlier in the lecture, from far-right groups, from conservative agencies, we want to make sure that our LGBTQ patients and communities have a powerful voice, and Stanford has the ability to be that voice, to advocate for these patients, their right to access care, their right to health, and the right to be themselves and exist in a space that is free of discrimination. And as I mentioned earlier, we are so proud to be the site of education for many of our LGBTQ and non-LGBTQ identified students. We know that by having a space which is available for students to learn about LGBTQ medicine and to serve as LGBTQ mentors, our students who are in this community can see for themselves a place in medicine. Many of our students earlier said that they had difficulty, they struggled seeing a place in medicine for themselves and a career for themselves. So being able to be role models and for those patients, for those students, allows us to really serve not just as an educational role, but also as a mentor. All students, regardless of whether or not they're in the LGBTQ plus community or not, also benefit from the education that we provide. They exit Stanford understanding the basics of LGBTQ healthcare, of gender-affirming hormone therapy, of sexual health as it pertains to all genders and sexualities, and not just what would be the general population, the non-LGBTQ population. And so they would leave having this extra bit of empathy and compassion that we hope to spread and extend to all medical institutions. So thank you so much for having me. This was wonderful. Happy Pride, everybody. I always like to end with saying that Pride, though we think of it as celebrations and rainbow flags and glitter, it is a constant call for us to do better, to serve our communities, to be able to be compassionate and kind to people, and to elevate people from a place of being discriminated against and stigmatized to a place where they're not just tolerated, but celebrated and welcome. Thank you.
Thank you, Dr. Laniakea. I suppose you could stay right over there and I'll come over here. Yeah. I'm glad you reminded us that it's a Pride Month. And I also need to remind everyone that there are new Zoom backgrounds for all of us in the Department of Medicine. So that should be in the links. They are fabulous. Thank you to the communications team. So I see the questions are starting to come in. And as the questions come in, I do have one question I want you to elaborate for folks. We've often had this conversation of the tension between kind of some of the data that shows that folks would want all their medical providers to be skilled in caring for diverse populations. So how do we balance that with the need for a specialized clinic?
Yeah, so in an ideal world, there wouldn't be necessarily a need for LGBTQ specialized clinics, right? There would be simply every single provider would have the ability to provide excellent LGBTQ care as well as non-LGBTQ plus care, right? And again, the hallmark of good LGBTQ health is good primary care. Not to say that other specialties aren't important, right? But we start with good screening. We start with good preventative care. We start with an excellent social history to see what the patient needs, right? And if we can expand out that expertise, awesome. And that is the someday goal. But for right now, there are so many questions that are unanswered that if we are able to provide better care for if we have our patients together and we can start to say, hey, with this patient population, let's get some answers for what is good LGBTQ care. We can't even provide it. We don't know what it is yet.
Thank you for that. I think Dr. Barry, Dr. Barry had a question earlier.
So I have a question. So about 30 out of 50. Oh, they won't hear online. Thank you, sir. Next session.
First of all, thank you for that presentation. And thank you for being here. So I have a question for you about global anti-LGBTQ+. It's now 30 out of 54 of the countries in Africa have criminalized homosexuality. I'm sure you know that Museveni just signed a bill, the death penalty in Uganda, for what he's calling aggravated LGBTQ activities. Do you know of any, and I really haven't heard of any activism really being put forth around global anti-gay sentiments, and particularly in Africa. Moreover, that Uganda bill was actually penned by evangelicals in the US. So I'm curious as to your comments on this.
Absolutely. I think that it is just an incredible shame that I think in the pro-LGBTQ, or rather, I would think of it as the pro-human, right, component, that oftentimes we find ourselves playing catch up, right? That like I mentioned, over 400 anti-LGBTQ bills are being pushed for the United States, right? Meanwhile, bills trying to protect and trying to, to kind of mitigate some of this damage or to prevent it from happening are in the dozens maybe, right? And so it's an absolute shame, right? And when we see that, again, the anti-LGBTQ movement has tried to start pushing their agenda globally, again, like as you mentioned, a lot of these bills around the world don't come from the countries that they are being enacted in, but rather here in the US. It is, I guess, infuriating for those of us who are trying to push advocacy from our own grassroots organizations, that we can't go faster, that we get pushback from what I would say would be even the moderate voices. And I sometimes, hear the voice of Martin Luther King, mentioning that sometimes the greatest enemy to progress is not the conservative, but the moderate.
Any global activism within your groups in the US?
Not that I'm aware of. Yeah.
And Dr. Harrington.
First up, Angie, I'll join with Michelle. Thank you. Thank you for that terrific overview. And I have a whole series of questions, but let me just ask two of them. First off, if people who are on Zoom want to reach you at the clinic or reach somebody who can schedule them at the clinic, maybe you could give the details as to how they do that. And then my second question has to do with something you and I have talked about. There is a increased risk of cardiovascular disease amongst our patients who represent as LGBTQ for a variety of reasons. We now know that statin therapy is really improving outcomes with a big clinical trial. How do we make sure that the subspecialists in our department are aware of some of these issues? Are there certain groups of subspecialties that you in primary care would like to have a better relationship with? How do we do this? How do we get better organized? Because I'm going to guess I asked from the perspective of a cardiologist, but I'm going to look around the room. I'll bet all of the subspecialists could ask a question that's germane to their specialty. So how do we make sure that this group of patients is getting optimal care?
Absolutely. As I mentioned, our LGBTQ plus program is not a singular department. It is not, it is not a singular space, but rather it encompasses many specialties. I encourage you, if your department doesn't have someone who's already engaged in LGBTQ health, let's come up with someone, talk to me. Let's see if we can set up an ambassador for LGBTQ health, or someone who can be kind of embedded in our LGBTQ plus program, not just to add their specialty to the LGBTQ plus program, but so that information can flow both ways, right? As data publications and literature advance for LGBTQ health, how we can make sure that our departments have that open bandwidth band for communication, such that we can communicate to you that these new studies are coming out that may show that our LGBTQ plus patients that may show up in your practices, in your emergency rooms, in your ORs, get this care. In order to, you can refer to the LGBTQ plus program. You can have the patients call 650-724-8844. That's our LGBTQ plus scheduling number. That is actually on our website. So if you search for the Stanford LGBTQ plus program, it'll be maybe not the first one that comes up, oddly enough, but it'll be one of the first results that pops up on. We're working on that with our marketing team. It'll be one of the first things that pops up, the Stanford LGBTQ plus program, and our phone number is there. Patients can call. They don't need a referral. They can call and schedule. We take almost every insurance. So please, if you have a patient who would benefit, and again, if you have a patient, maybe you're their primary care physician, or they already have one, you're their specialist, and you want them to see us, we don't have to take you over as their primary care. You can refer to us. We'd love to consult, help them with whatever is germane to their own patient their own health care concerns, and then have them continue and follow up with you. Yeah, thank you. Great question.
I have a few from the Zoom, all the folks in the room gather their thoughts. So one of our residents who is at the VA asks if you are aware of anything about efforts at the VA for delivering care for LGBTQ plus patients.
We're not currently partnering with the VA, but I would love to engage with their directorship there and see what we can do.
Okay, that's great. And then another Dr. Sophia Yen asks, which nonprofits do you think are most helpful if one wants to donate or support?
That is difficult, and I think that it would be hard for me to say which nonprofits to go to specifically without endorsing them. And I often will say that you should probably make sure you're researching them a little bit. But Larkin Street Youth in San Francisco is great. Our transgender youth are 20 times more likely to be homeless than their non-LGBTQ plus peers. So it is like in helping them provide space for themselves, I absolutely advocate that you check out Larkin Street Youth. Also, the Trevor Project has worked tirelessly since the 90s in order to help create spaces that are safe for LGBTQ patients, youth, and their families.
Along those lines, Dr. Sushianan is asking, she thanks you for a great talk and safe medical home that you've built. She's wondering about the significant social disadvantage. You mentioned a few community partnerships. Are there any more that we could be reaching out to in terms of sending our patients if they lack insurance or financial resources?
Yeah, so the patients who are on, so first of all, I don't know of any just blanket LGBTQ plus organization that provides funding for are patients who are struggling with finding resources for gender affirming surgeries, or even for those who are lacking insurance. But we do have through the county, Santa Clara County has the gender clinic there that is available for patients who have county-based Medicaid who can't see us over here at Stanford. We also partner with the LGBTQ plus youth space in San Jose to help provide basically mentorship and guidance for some of the LGBTQ youth that work through there.
So shifting gears a little bit to education, and since you are a beloved educator for many years here at Stanford, I'm not sure if this question is relating to Stanford alone or med school in general, but what do you think can be done to ensure that the care of LGBTQ plus patients will be part of core curriculum in medical school?
Yeah, so we are currently, so I also, as Wendy mentioned earlier, Dr. Casares mentioned earlier, I am honored to be the theme lead for sex, gender, sexuality, and sexual function at the Stanford School of Medicine, where we now have approximately 19 hours of education for LGBTQ in the core curriculum. This is for most of this is mandatory for our students to go through. This is not a optional, lunch lecture or something that our students can opt out of. All of our students get to learn about LGBTQ health and graduate with that. Moreover, we are taking the data that we learn about educating our students on LGBTQ health, and we're presenting it at national conferences. We're publishing it. We're trying to disseminate it out to other institutions to make sure that they also start to have the same resources that we have for teaching their students.
And I think along those lines, I know, Pedram, you're wondering how we're going to get this for the residents and the fellows.
I would be happy to collaborate with the residency programs. If anyone wants to reach out, I would love to work with you.
We have actually a clinical question here. So Dr. Lebowitz is wondering, what complications have you seen in XX individuals? Is how they phrased it, attributed to chronic testosterone treatment. And are there any implications for folks who have XY at birth who also want anabolic steroids?
Sorry, which complications regarding that, or just complications in general?
Yeah, for chronic testosterone treatment.
Well, I mean, the complications are as you would expect, right? They get acne, flushing, balding, everything that's associated with male gender, right? When we start testosterone and hormone therapy in general, sometimes it seems very daunting and scary, but it's actually, in order to develop secondary sex characteristics in this patient population, we're putting them through puberty, right? And it lasts just as long as puberty, usually 3, 5, 7-ish years, depending. Everyone plateaus a little differently, right? And they get the same characteristics. Now, of course, there are things, as we mentioned, the administration is not perfect. Testosterone is somewhat of an anabolic steroid, and the way we administered it is also erythropoietic, right? So sometimes our patients who have, perhaps a genetic predisposition for polycythemia may have not had testosterone on board and may not be generating an excessive number of red blood cells or an excessive amount of hemoglobin. But then once we start testosterone, we do see actually a polycythemia develop. And so we do monitor all of our patients very regularly on testosterone for any sign that the hematocrit or hemoglobin is elevating to supraphysiologic levels. Aside from that, it would really, we don't see any long-term chronic testosterone complications. There may be balding, but that may happen anyways with genetics, right? If the patient had been born with testes, there may be acne early on, flushing, which could lead to scarring, right? Which we make sure we are partnering with good dermatologic care, the same that you would provide for routine acne vulgaris care for these patients. And of course, if the acne is worse, we would provide them with we would provide them with dermatologic care. We actually have LGBTQ plus dermatology. Rarely, the cessation of menses and the effects of testosterone on the uterus may develop endometrial hyper or hypoplasia, depending, and that is usually observed with abnormal uterine bleeding, and we'd monitor that with our colleagues over at gynecology. Rarely it needs intervention. And then sorry, there was a second part of that question?
I think you've hit the nail on the head for the most part.
Okay.
On that one. So I think we were earlier talking about how else the department can be involved. And one thing that comes to mind for me is you mentioned a lot about how the Los Altos Clinic is a safe space. What are like the key components you think that us as clinicians in our own spaces can advocate with our clinic administration and SHC for all places to feel comfortable? 'Cause I can say from personal experience, they're not all welcoming.
Right. Yeah, yeah. And again, for those of you who feel like, I don't want to, I'm not here to attack anyone's department or say like, you're not a safe space. I'm just saying we all like, we started off at Los Altos having a lot of patient complaints, even when we started the LGBTQ plus program. So we did lots of iterations, we improved, we changed little procedures and processes in order to make sure patients felt comfortable, right? And some of that is, hey, we couldn't change the billing, for instance, like billing had to be sent to legal name for a long time, right? And so what we did was we prepared the patients. We said, hey, you may be getting some information, right? So three big things, right? We want to be as respectful as possible and use names and pronouns the patients use for themselves. That sounds straightforward, but it's not, right? When the documentation on the chart is all legal name, it's very easy to say like, oh, please, Benji, can you come back for your appointment? Rather than setting up a procedure. For instance, at Los Altos, we call patients back by their last name and their appointment time, right? So that usually works. We never have two patients at the same time with the same last name, typically speaking, right? And if there is, we can verify with date of birth at the front desk. And we also provide a space on our intake forms for patients to put down a name they would like us to use, if that's not necessarily their legal name. And you'd be surprised, it's not just our LGBTQ plus patients using that. A lot of our patients are using that space. And we also have a space to provide pronouns if the patient wishes to provide them, right? Moreover, when we set up spaces like this, our patients don't, and we call the patient whatever name at the top, even though the patient doesn't go by that, they don't get upset because that's the name they gave us. They don't feel like we're disrespecting them. They can easily correct us in the room, and we can just verify in the room that that's the name and pronouns that they'd like to use. Sometimes, they're filling out the form with someone looking over their shoulder. So, they fill out whatever, and then they correct us in the room, and that's fine, right? So being respectful. The second thing is we want to be precise. I think it's human nature, especially us as physicians who are taught to ask a million questions. Everyone remembers the old carts, right? We're onset, location, right? And all of these questions, right? And get a full history when a patient comes in, but for some of our LGBTQ patients, especially gender affirming patients, right? When they come in and they're here for their broken arm, they're here for ear pain, right? And you're saying, well, you're transgender. What kind of genitals do you have? Let's talk about what surgeries have you had in the past. It can feel very invasive. So we want to be precise. We want to ask the questions that are really pertinent to the situation at hand, the current medical complaint, and ask other questions, right? But also, sorry, I'm going to contradict myself right here, but my third component of this is we want to be transparent, right? Like I mentioned, with that billing cycle, there's some things we can't change. We're working on changing it. So you can let your patients know we are working on changing our entire medical system to make sure that it can be respectful, right? But with some things, they will get messages addressed to the wrong name. Being transparent that may happen, but also being transparent when we need to ask a specific medical question. The patient I mentioned earlier broke their arm, right? Let's say this is a trans feminine patient that broke their arm, right? And we're saying, I really want to ask about, hormone therapy because it may be relevant to the arm, right? For instance, if this is a transgender woman and she had an orchiectomy, removal of the testicles, she knows no longer producing testosterone, and perhaps she hasn't been on estradiol for a while because she hasn't been able to get it. Her provider was from another state. She moved here, doesn't have access. She doesn't know where to get hormones now, and she's been on no hormone. Well, she may actually be going through osteoporosis, right? She may have low bone density, which may relate to her broken arm. So how do we ask that? Let's be transparent about it. So I'm about to ask you some questions about your hormone therapy. And the reason I'm going to ask this is because, bone density is often related to hormones, and that may have caused your broken arm. I'm just worried about that. I want to ask you some questions of that. Is that okay? Right? And by setting up those three principles, we've actually answered most of those situations in making the clinic a safe space for our patients. Obviously, there's still always little details and things, nuances that you can change to make the clinic even better. and things that we've been working on, processes that can be iterated. But I think that's the core principles.
Yeah, I have a quick follow-up before turning it over to Dr. Harmon. And how have you been able to partner with SHC as well in terms of the training of the rest of the clinic? The front desk, the MAs.
Yeah. So again, at our clinic, we're very direct, but we've also been working with SHC in other clinics, right? To work with their staff to give quick kind of catch-up lectures. We think of them. The recommendations from Fenway are to do biannually kind of sessions to go over terminology in the community, to talk about names and pronouns and respectful address, to talk about these 3 principles that we mentioned, so that our staff isn't blindsided that says, suddenly I'm trying to think of everything I learned about for LGBTQ health back when I got hired during that one health stream modules. But now I'm saying, like, this is something that comes up frequently. This is something that I learn at least twice a year, even if I don't, so that when a patient comes in, we're prepared, we're ready, we have our processes in place and these processes are often, again, like I mentioned, helpful for everyone. My mom often doesn't go by her, her legal name on her driver's license, right? She has a name that she prefer people to use because sometimes her name can be difficult to pronounce for English speakers, right? So she uses that name, and this process helps her. She's not in the LGBTQ community. She loves me very much, but she's not in the LGBTQ community, right?
Dr. Harmon?
Thank you, Dr. Laniakea. This is a kind of a continued thread with regards to training. I was curious, you mentioned some of the work in the clinics with regards to training, really for the clinic space. I'm curious about kind of the We Ask Because We Care initiative on the inpatient side in the hospital, where I think there's a lot more kind of unexpected admissions, and oftentimes, I wonder about kind of the experience of our LGBTQ plus patients coming through into the acute care setting.
So the question is how does We Ask Because We Care planning to help address the LGBTQ patients coming into
the inpatient in the inpatient kind of the whole inpatient setting between the emergency room, admission, obviously a lot of different clinicians and team members who are interacting with patients. And so, I was just curious. I'd seen that some of the initiatives rolling out, but it was, from the We Ask Because We Care kind of info sessions separately from kind of what we're doing with regards to the kind of inpatient setting.
Right. So I don't want to promise too much because I'm going to say this and then things might change as the rollout goes. But the plan is to have patients, rather than having legal name at top of chart, right, to first display the names that are appropriate to refer to the patients as soon as we have those data, right, to have the patient to gather the information that is pertinent to the patient's communication and put it at the top of the chart. Right. And then rather than just having a legal name there and trying to say hey, now we have to correct ourselves or try to, fight the patient to figure out what it is. Right. And I don't think anyone's ever run up to a patient in cardiac arrest and said, but what's their legal name? What's the legal name? Right. You want whichever name is going to get the patient to respond to you as quickly as possible so you can keep on going and with your medical care. Right. And that again also helps all of our staff in the medical settings too, such that they aren't confused to which patient we're addressing if we're all using the same names for the patients.
Any last questions? Okay, with that, then I'd like to thank Dr. Benji Laniakea for coming to speak to us all and sharing the program. I hope more and more people get to know more about the program from the early days when patients would just try to catch a glimpse of the rainbow on the badge and find the clinic to now. And happy Pride. And I believe Stanford's going to be at Pride, which is a welcome change over the last few years. So thank you for all the work that you've done over the years.
Thank you so much for having me.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.